Good evening, everyone, and welcome to tonight's edition of Eversight's webinar series, Cataract Surgery in Fuchs Dystrophy with Dr. Divya Srikumaran. Just a few quick notes before we begin. All participants will be muted throughout the webinar to eliminate background noise. You can type questions that you have for Dr. Srikumaran at any time into the Q&A panel at the bottom of your screen. She will answer those at the conclusion of the webinar. And now I'll just give her a brief introduction. Dr. Divya Srikumaran is an associate professor of ophthalmology in the Division of Cornea and External Disease at Johns Hopkins Wilmer Eye Institute. She received her medical degree from Northwestern University Feinberg School of Medicine, after which she completed her ophthalmology residency and a cornea fellowship at the Wilmer Eye Institute. Dr. Srikumaran's research interest includes the assessment of corneal transplant outcomes and risk factors for receiving keratoplasty through big data sources, including administrative claims data. She received the Hopkins Center Iris Registry Research Fund Award through the American Academy of Ophthalmology, as well as the EBAA Pilot Research Grant to study real-world endothelial keratoplasty outcomes. She's leading a team to integrate Wilmer's clinical data into the IRIS registry and the source EHR repository. She's also a renowned educator, currently serving as the Vice Chair of Education and previously the Residency Program Director. As Vice Chair of Education, she has an interest in medical education and studying best practices to support doctors in training. Blending her passion for both education and expertise in corneal surgery, Dr. Srikumaran has also studied barriers to adoption of advanced keratoplasty procedures by cornea specialists in the US and abroad. And now I will turn the floor over to you.
Thank you so much, Michael, for the introduction, and thanks for having me. Welcome everyone to the webinar. Thanks for listening. So as many of you already know, Fuchs corneal dystrophy was first described by Ernst Fuchs, an Austrian ophthalmologist, over 100 years ago. In 1910, he first noted the epithelial bullae that occur in the late stages of this disease and named it dystrophia epithelialis corneae. It wasn't until later that we discovered that the underlying problem here was actually of endothelial dysfunction and the guttae that are seen classically on exam, as shown here on the images. It's a hereditary condition with a female predilection, and symptoms often begin in middle age. This is currently the most common indication for keratoplasty in the United States. So the treatment of surgical treatment of Fuchs has evolved over the last 20 years from full thickness grafts to endothelial keratoplasty. Most recently, it's evolved from DSEK surgery to DMEK, and in the future, we may see this progress to decimate stripping only or other cell-based therapies. But for the time being, DMEK is the mainstay and standard of care in the United States. So as we can see from the EBA reports in the United States, the number of DMEK procedures have been steadily increasing over the past decade. And in 2021, the number of DMEK and DSEK procedures were nearly the same. So in general, our improved visual acuity outcomes and the lower risk of EK compared to PK surgeries have changed our threshold for offering keratoplasty to patients with Fuchs. And this in turn has resulted in a shift in our approach to cataract surgery in eyes with Fuchs corneal dystrophy. In particular, when considering a patient that has both Fuchs and cataract surgery, it's first and foremost most important to make an accurate diagnosis and to recognize the corneal condition and to counsel the patient on the risk of corneal decompensation or potentially perform a concurrent cataract surgery and keratoplasty procedure and to manage the patient's expectations accordingly. So when approaching a patient and when trying to determine whether a combined triple procedure is appropriate, it's first important to distinguish the cause of the visual loss. Is it the cataract or is it the Fuchs? And this can be done through a variety of methods, including, of course, history and assessing the patient's symptoms, careful examination, and then diagnostic testing. So in terms of evaluation, a lot of the symptoms of Fuchs and cataract can overlap, including glare, blurry vision. Patients with cataract tend to have myopic shifts and may report some change in color perception, but Fuchs patients also will have changes in their color perception, which is more noticeable after surgery. But some symptoms that may be more characteristics of Fuchs would be morning blurry that clears throughout the day. So patients with milder edema may have edema that's present in the morning, but then as the cornea detragresses throughout the day, later may have some clearing in their vision. And then patients with advanced Fuchs may have foreign body sensation or discomfort from the bullae as well. Specular microscopy can be helpful. It's well known that you need about 500 cells per millimeter square to maintain corneal clarity. And it's well accepted also that cells counts of less than 1,000, especially in patients with Fuchs, are likely to compensate after cataract surgery. However, in patients with Fuchs, it can be difficult to get accurate measurements of endothelial cell counts, and cell counts do not necessarily assess function. Normal specular microscopy, however, can be very reassuring in these patients. Central corneal thickness has also been helpful. This is a study that was done at the Wilmer Eye Institute several years ago and had demonstrated that patients with a central corneal thickness of less than 640 had a much lower odds of receiving penetrating keratoplasty compared to those with a central corneal thickness greater than 640. However, absolute cutoffs do not account for changes in baseline corneal thickness, and it's easy to miss subclinical edema. The threshold for EK is also much lower than that for PK, as we already mentioned, and so the 640 cutoff may not be entirely relevant for all of our patients. More recently, Dr. Patel from the Mayo Clinic and the cornea service there have identified tomographic features that can be very helpful in identifying subclinical edema. Through a series of papers, they've identified 3 primary features on the pentacam here shown. One is the irregular isopachs. So patients, rather than having concentric rings, have irregular isopachs as shown here. There's nasal displacement here of the thinnest point relative to the center. And then if there's focal depression within the central 4 millimeters of the cornea, the presence of any of these 3 features would be indicative of subclinical edema. So this is a case where the use of all 3 types of diagnostic testing was helpful in addition to the exam in coming up with an accurate diagnosis and plan. So this 83-year-old gentleman was referred for cataract surgery in the setting of Fuchs. He had decreasing vision in his right eye. He had already had a phaco-dissect for Fuchs corneal dystrophy in the left eye 4 years ago at an outside facility. On exam, his vision was 20/70 in the right, 20/60 in the left. He had very few guttae, however, in the cornea and prominent corneal nerves. The left eye had a clear dissect graft. He had a dense lens. And in the right eye, the pachymetry was elevated 644. The left eye was 757, but again, this is post-DSEC. So a pentacam was obtained, and the pentacam actually does not show in the right eye any of the classic tomographic features suggestive of edema. A specular was obtained, and the specular also showed a relatively healthy looking endothelium on the specular in both eyes. Again, the left eye had a graft. So this raised doubt in addition to the exam of even the diagnosis of Fuchs. If he had it, it was incredibly mild. So we planned to perform just a cataract surgery. He had a history of macular degeneration, so that was also contributing to his decreased vision, and no DMEK was performed, and the patient has done thankfully quite well. So again, just to highlight the use of all of our diagnostic tools in making accurate diagnoses and management plans. So in patients that have visually significant Fuchs but no cataract, DMEK alone can be considered, especially for young patients. This series from Dr. Mellis's group in the Netherlands compared phakic and pseudophakic eyes that had Fuchs corneal dystrophy and demonstrated both comparable best corrected visual acuity at 6 months, endothelial cell loss, and rebubbling rates. Furthermore, they found that the cataract surgery rate was less than 20% at 5 years. So for young patients with residual accommodative power, a DMEK alone would be preferable. This is the case of mine, 47-year-old patient that I've seen recently. She was referred in actually for possible post-LASIK ectasia. She had a history of LASIK 23 years ago, and you can see here her manifest refraction, which does show a high degree of myopia and some astigmatism. She reports, though, that her prescription for her glasses has been stable and has not changed much, although lately they have not been helping her. On exam, we noted 4+ guttae in both eyes, and there was also paracentral stromal edema in the left eye. Both eyes had a LASIK scar. Her lens was clear. On pentacam, we could see that the left eye does have a high degree of corneal irregular astigmatism and inferior steepening. Both eyes actually had some inferior steepening, but in the left eye, despite this eye being steeper, the corneal thickness was actually greater. There are some changes to the contours with irregular isopax here as well, although it's difficult to interpret the tomographic features in the setting of an eye that has had prior LASIK and possible post-LASIK ectasia. However, the edema was present both on clinical exam and again, the pentacam did show some thickening. And so our plan is to do a phakic DMEK, and given her age and given the irregularity in her cornea, it was felt that it would be better to do a phakic DMEK first and followed by cataract surgery later at a time once her cornea is more stable. So in patients that have both mild Fuchs and a significant cataract, careful cataract surgery alone can be considered. But again, it's difficult sometimes to detect subclinical edema or predict which eyes will decompensate. So these patients need good counseling. This is some data from our recent Medicare claims analysis. This is still unpublished, but what we had found is that in over 700,000 beneficiaries with Fuchs, the risk of a first-time EK or PK was about 4.5% in the overall population. For patients that specifically had cataract surgery, this Kaplan-Meier curve shows that the rate of endothelial keratoplasty after cataract surgery in the same eye is about 2.4% overall over an 8-year time frame. The greatest risk is in the first year. So a large number of eyes with cataracts and Fuchs don't end up requiring keratoplasty. And so when in doubt, I think it's always safer to be conservative and do a cataract alone followed by DMEK later if needed. So this is a patient of mine, 66-year-old female, history of Fuchs corneal dystrophy, and was presenting with blurry vision, trouble seeing the computer in small print. She also had a cataract. Her visual acuity is mildly impaired, 20/30 in the right eye, 20/40 in the left eye. She has some guttae on exam and a visually significant cataract, slightly thicker pachymetry in the left eye. Her specular here shows perhaps slightly higher cell counts in the left eye compared to the right eye, although this is again a small sample here. And it does confirm the presence of the guttae that we saw on exam. And then on pentacam, we can see that actually in the right eye, she has more features of subclinical edema in the sense that she has the irregular isopax and she has nasal displacement of the thinnest point. In the left eye, she has some mild irregularity to the isopax, but otherwise none of the other features. So our plan for this patient is to just do a phaco alone and DMEK later as needed, even though the left eye has slightly higher pachymetry, given that there are no signs of subclinical edema on her pentacam and the relatively normal looking speculum. So when doing cataract surgery alone, there's multiple strategies that one can use to try to minimize endothelial cell loss. And one option is first, of course, to consider cataract surgery in an earlier stage. The less dense the lens is, the less phaco energy that's used and perhaps less endothelial cell loss. One can also consider performing a scleral tunnel incision instead of a clear corneal incision, or to place a suture instead of using stromal hydration to close the wounds. It's also important to carefully remove all of the nuclear fragments to ensure that there is no retained fragments that would contribute to corneal decompensation. For surgeons that are very comfortable performing manual small incision cataract surgery, this may be the preferred option for dense cataracts, as this would reduce ultrasound energy. And then the Arsenault soft shelf technique has also been advocated as a way to protect the endothelium. And in this case, a dispersive viscoelastic is placed closest to the corneal endothelium with a cohesive or viscoadaptive closer to the lens surface for the anterior capsule during the reticis. In general, with respect to IOL selection, I recommend caution when using premium lenses, especially presbyopia correcting lenses for patients in which the guttae are going to be left behind. They can impact the visual quality and result in suboptimal outcomes. The patients also tend to have quite irregular astigmatism. Again, if there's any subclinical edema, this can result in irregular astigmatism. And so toric lenses also should be used with great caution. I tend to recommend aiming for myopia for the possibility of a future EK, and also avoid hydrophilic lenses in these cases, again, in the case that the patient may undergo a future EK. This is a study that evaluates the use of femtosecond laser. So this is done by Dr. Ku's group at Bascom Palmer. And what they found is that the risk of corneal decompensation was the same in patients that underwent femtosecond assisted cataract surgery compared to the conventional technique at 3 months. Another study from Singapore had demonstrated that there was lower endothelial cell loss in eyes that underwent femtosecond assisted laser cataract surgery. But there was variable follow-up, and the time for endothelial cell loss was different for each patient. And so while the results are missed, I think it's ideal for surgeons to use whatever technique they're most comfortable with to try to optimize their outcomes. So finally, patients that have both visually significant Fuchs and a significant cataract can undergo either combined procedures or staged procedures. And when thinking of combined procedures, the advantages include faster visual recovery, less cost, there's reduced risk of having 2 procedures in terms of infection, and lower cost to both the patient and the healthcare system. Some considerations when considering stage procedures are that you could have both first the cataract followed by DMEK, or possibly the DMEK first. Cataract followed by DMEK oftentimes may be based on surgeon experience, financial and other logistic considerations, or patient preference. And then of course, DMEK first could be used to enhance refractive outcomes, but there are risks to the graft, including endothelial cell loss, graft attachment, or failure. So this study from the Price Vision Group had evaluated nearly 300 pseudophakic DMEK cases to 200 DMEK triple cases, and they found no difference in postoperative vision, endothelial cell loss, or complications at 3 to 6 months. So they advocate for combined procedures if the surgeon experience warrants it. This is a more recent case series from another institution in which they found that while best corrected visual acuity and rebubbling rates and rejection rates were comparable, the endothelial cell loss rate at 1 year was significantly lower in the pseudophakic DMEK group compared to the DMEK triple group. So they advocate perhaps for stage procedures. However, the mixed results really here, I think, point to the fact that surgeon preference would be based on surgeon experience, and the decision to perform combined versus staged procedures, again, may also be influenced by whether there's any doubt over the need for the DMEK. So anytime that there's any doubt, again, it's better to do a staged cataract first, followed by DMEK only if needed, patient preference, and then again, financial considerations for either the ASC in terms of reimbursement for supplies and tissue. So this is a patient of mine in which I did a combined case. It's an 80-year-old female with a history of Fuchs corneal dystrophy and a cataract. She had had phaco-DSEK 15 years ago in her fellow eye, and she now presents with blurry vision that's been worsening over the past couple of years in her left eye. On exam, her visual acuity in the eye that was operated on was already 20/60. She had a clear DSEK graft. Her pachymetry is 681. In the eye that she was coming in for, her visual acuity has decreased to 2150. She has 4+ guttae, a thickened fibrotic DM, a dense lens, and her pachymetry is 651. So a specular was obtained, and in the right eye, you can see some endothelial cell loss. This graft, again, is 15 years old, so this is consistent with some loss in attrition over time. In the left eye, that specular actually was a very poor quality. It's hard to discern any of the endothelial cells there. Her pentacam again shows tomographic features of edema. She has displacement of the thinnest point. She has irregular isopax, and then some focal depression here seen paracentrally. So we did a phaco DMEK. Her visual acuity at 4 months was, at 6 weeks was 20/40. The graft is clear, as you can see her on this OCT, and her pachymetry has decreased from 651 to 466 post-op. So there's a few pearls when you're doing combined procedures, and one of them is to not place any dilating agents in the irrigating fluid if that's something you typically do, such as omidria or epinephrine. I recommend making a smaller rhexis so that the rhexis edge covers the optic edge. It's important in these cases to avoid capsular rupture so that the lens can be placed in the capsular bag. So use trypan if the visibility is low, phaco high out of the bag if you have to. You are going to be doing the DMEK after all. It's more important to not have capsular rupture or vitreous loss in terms of your overall ease of the procedure and outcomes. And then when you use a viscoelastic, it's very important to carefully remove all the viscoelastic to reduce the chance that you would have graft detachments from retained viscoelastic in the interface. And whereas when you're doing cataract surgery alone, a dispersive is recommended. In this case, a cohesive may be preferred. So this is one of my early cases, and it just highlights some of these teaching points here. So the rexus is small, and again, a small rexus will improve IOL stability. And what we usually do is place, initially I was using 3-piece lenses for all of my cases. This is a MA50BM Alcon lens. So it's a hydrophobic lens that has a 6.5 millimeter optic, which allows for stability of the IOL in the bag. I place Myocol in the eye to constrict the pupil and then perform a PI intraoperatively. We mark the cornea, and it's important to mark the cornea so that you are within your corneal incisions, both the paracentesis and the primary incision, so that there's no overlap between your planned graft and the corneal incisions. We strip decimates as usual. I do this under a viscoelastic, and then I carefully remove all of the viscoelastic. And then I do a pull-through technique. So this is a graft pull-through. For these cases, I did early on always place a suture as well. This just helps to maintain some gas bubble in the eye and to make sure that there's no inadvertent pressure on the eye that would then result in a shallow chamber postoperatively. So again, it's important to do a hydrophobic IOL. Consider a 3-piece. I've transitioned away from 3 pieces to doing a single-piece lens, but early on a 3-piece can be more stable in the bag. IOL calculations are inherently inaccurate. Oftentimes there's significant changes in the keratometry from the corneal edema. So hyperopic surprises are also common, and aim at least minus 0.75 to -1 more myopic than your intended target. And again, like the eyes with Fuchs alone that are having cataract surgery, I recommend caution when using premium lenses due to the inaccuracy of the IOL calculations. So this is our review of our Wilmer experience with the refractive accuracy. We compared multiple formulas in postoperative outcomes for patients that had DMEK triple procedures. And we found that with different formulas, the accuracy ranged from a mean error of minus 0.10 with the Haig's formula up to plus 0.90 with the Barrett formula. So again, I use the Barrett formula. That's my go-to formula for cataract surgery. So I tend to aim somewhere between minus 0.75 to -1. But even with this adjustment, it's very important to counsel patients about the refractive inaccuracy, because again, this is the mean error, but the spread is much broader. So this case is an example of why that's important. This is another one of my patients that had phaco DMEK. She had pre-op best corrected acuity of 20/60. She had stromal edema and gluteon exam. You can see again the tomographic features of edema on her pentacam, including the irregular isopaths, displacement of the thinnest point, and then the focal posterior depression. Her central corneal thickness was 580 pre-op. I had done a phaco DMEK, and based on the IOL calculations, I aimed for about -1, used the MA50BM. I implanted a 20 diopter lens post-op month 3. I was expecting with the 20 diopter lens that with the typical shift, I would end up close to plano. But as you can see here from a refraction 3 months post-op, she was a -1. So again, it's important to counsel the patients on the potential for refractive errors and the overall refractive inaccuracy with our triple procedures. This is another example of a patient of mine. He's a 72-year-old gentleman that had painful bullae with pretty advanced and asymmetric Fuchs dystrophy. The left eye had 2300 vision on presentation. He had epithelial bullae centrally with 4+ guttae. His pachymetry was 689 in that left eye compared to 536 on the other eye. We had planned to do a phaco DMEK, but we were unable to obtain reliable keratometry. The lens star couldn't get any measurements. On pentacam, again, he had the central bullae and central epithelial irregularities, so he had very steep keratometry in the left eye compared to his right eye. I ran the calculations using both the pentacam keratometry readings and his Ks from the right eye to do the calculations for his left eye, and there was a 4 diopter difference in the planned lens. So I ended up using the measurements from his right eye for his IOL calculations, and I placed a 14.5 diopter lens. 4 months post-op, he was 20/40 uncorrected. You can see that his pachymetry had improved from over 600 pre-op to 489. And thankfully, his refractive outcome was closer to our targets. He was a -5.5 and doing quite well. So what are some other options for improving our refractive outcomes? Well, one is to do the stage procedures with the DMEK first. Again, this would result in improved outcome accuracy of our IOL calculations because the cornea is now more stable. It would facilitate placement also of toric and or presbyopic correcting lenses. However, there is a risk of both graft detachment, endothelial cell loss, and graft failure with the staged approach with the DMEK first. This series from the Price Vision Group evaluated the use of presbyopia correcting lenses, and they performed stage procedures again with the DMEK first, followed by cataract surgery. And in these 60 eyes, they did get good results in terms of both uncorrected distance and near vision with these premium lenses. Another option would be to use the light adjustable lenses, which are more recently available in the United States. This is a case report with two patients with 2015 uncorrected visual acuity in their dominant eye with the light adjustable lens placed during the time of a DMEK triple procedure. So this could be a nice option so that we can do combined surgeries, but still improve our refractive outcomes rather than having to do staged surgeries. So in summary, I just want to share again that this sort of original algorithm, again, the most important first step is to distinguish the cause of vision loss and then to counsel the patients about both options for treatment and all of the possibilities. But that first step is, again, most critical. So thank you so much for listening, and I'm happy to take any questions.
Thank you so much for the presentation. I'll ask a quick question while our see if anybody give everyone a chance to type in any. You mentioned at the beginning of the presentation the higher prevalence of Fuchs in women.
Yes.
As well as the age of onset. What is the prevalence of Fuchs in the overall population, and how does it compare between the sexes? And then are there age-related differences in the onset?
Yes, so thanks so much for the question. Yeah, so we don't have great recent data on the overall prevalence. Sort of going back to some of the Medicare data that I was just quoting, we think that the minimum prevalence is probably around 1%, so it's not that common, and it is probably 1.7 times more common in women than men in terms of the diagnoses. There's based on the genetics, you can have both early onset and late onset disease. So when we are looking at Medicare beneficiaries, the reality is we are probably selecting for a later onset disease course compared to patients who've already had keratoplasty earlier on. But there's a lot of variability based on the genetics. And so in terms of female predilection, in terms of disease courses and the genetics that are there for both men and women, and perhaps some of the factors like estrogen and sort of biologic differences, it's a very nuanced picture that I don't think it's as straightforward as we would like it to be. But it's certainly in the United States, as we can see, it's far more common in women. And when we look at a lot of our case series that are published, majority of the patients tend to be white, and they tend to be more women than men in most of our case series, like 60-40 split in terms of patients who are having keratoplasty surgeries.
Thank you. I have one more question, I guess, if no one's typing any in. In the study you cited where they looked at endothelial cell loss, I think 6 months after triple versus pseudophakic DMEK. Was there a theory in that paper, or do you have a theory as to why in my head, like the cataract surgery is done and then you do a DMEK with a constricted pupil like you normally would. Do you have a theory as to why they found a higher cell loss in the triple procedures?
So I think that has to do probably with the intraoperative manipulation. So when you're doing a triple procedure at the same time, sometimes the lens is more unstable. And when we were doing our typical technique, the conventional technique for DMEK, you're shallowing the chamber. And so if the IOL is less stable, perhaps there's a little bit more contact between the IOL and the graft, or it just takes a little bit more time with manipulation, more time to unfold. And that can sometimes, I think, contribute to greater endothelial cell loss. So I think it's most likely intraoperative manipulation, basically.
Interesting. We have another question, two questions. Is there a correlation between Goutte severity and the thickness maps?
So to my knowledge, there isn't a great correlation between the Goutte severity and the thickness maps. I think a lot of the patients that tend to have more advanced edema tend to have more significant Goutte, but I don't know that there is a direct correlation.
Okay, thank you. And then the second question from Dr. Lass is, has the advent of DSO changed your approach to the management of patients with cataract and Fuchs?
Yeah, thanks so much for that question. So I think that there's the role for DSO and these patients is still evolving and still not clear. I think that there's some patients that clearly, there's some patient selection that needs to go into this. And the literature suggests that maybe that you need to have patients that have central Goutte, that have clear peripheral or preserved peripheral endothelial cells. But sometimes that can be very challenging to determine with examination and with our typical specular microscopy that we have available. And so it can be quite difficult to figure out who is a good candidate for this procedure and who is not. And I think in general, there's a lot of patient expectations and their needs. So with patients that are undergoing DSO, the prolonged visual recovery is something that can be quite challenging for a lot of patients. And so it's harder to find both clinically and from a social and patient standpoint, the right mix here. And for me, I would say that most of my patients, I'm still offering DMEK for the patients that have visually significant edema and who are looking forward to having faster visual recovery. So I haven't found that I'm using DSO very often in my own practice, but I'm looking forward to sort of getting more data on the outcomes longer term, as well as better guidance on who really would benefit from this procedure.
Great, thank you so much. There are no other questions at the moment. So we'll go ahead and close. And thank you so much, everyone, for coming tonight. Thank you, Dr. Srikumaran, for lending us your knowledge and expertise for the evening. This webinar and all of our webinars will be available on our website, eversightvision.org/webinars. As an attendee, you'll receive a very brief survey related to the webinar. Please take a moment to let us know what you thought. Thank you to everyone and have a wonderful evening.
Thank you.
Good night.
Good night.